the meantime, may I call Dr. Bhavesh Saha to present his paper on when it's all blue during phacoemulsification 2.
With the trypan blue under air technique, and to get adequate dilatation and to perform a good capsulexis, we use both adequate amount of viscodispersive and viscoelastic substance. And phaco was performed by phaco chop technique, but while during the last piece of the emulsifying the nucleus, I noticed there was a absence of red glow. Anyhow, we performed the phacoemulsion completed with the, an IOL was implanted with almost utmost precaution. And on the first post-operative day, vision was 6/9, but there was a bluish tint visible on the fundus examination. This blue glow disappeared after second post-op day, that is after 1 week. So in discussion, trypan blue staining of the posterior capsule and vitreous commonly seen in case of the general compromise either due to trauma or previous surgery or pseudoexplanation have been reported previously. In our case, the patient was a young male who had no sign of general compromise on preoperative examination, or nor there was any history of trauma or surgery in the past. So we intraoperatively, I use both dispersive as well as cohesive OVD in the excessive amount to achieve adequate dilatation to facilitate a good capsulexis. So elevated IOP from the additional viscoelastic introduced into the anterior chamber might have forced the dye posteriorly, where it was able to flow through the structurally normal zonules. This our hypothesis supported by Marx and co-worker and Pellet et al. Both are reported forceful inadvertent deliver of the high pressure dispersal of the blue into AC lead to migration of dye into posteriorly. And in another report, the Burkholder et al. Had published an observational case series where he had used iris detector before staining the capsule and had found inadvertent staining of posterior capsule with the dye. They had proposed the elevation of the iris with the detector and elevated IOP from the additional viscoelastic as a probable mechanism of the posterior capsule staining. So there are few preventive strategy reported in the literature, that is, we can use dye injection under the viscoelastic in place of under air, and we can create a viscoelastic barrier into the peripheral iridocorneal space, and we can use the mixture of trypan blue with the viscoelastic material such as Hilon GB3. So our conclusion is our case highlight the possibility of vitreous staining of the trypan blue in an eye with no clinical sign of zonular dehiscent and most probably due to raised IOP secondary to the OVD. So ophthalmic surgeons should be aware of this unusual complication resulting in poor visualization during the surgery and theoretically increased chances of intraoperative complication, and should employ the preventive strategy. These are the references. Thank you.
Zonular dehiscence, you must use trypan blue with
Yes,
caution.
in cases of
If there is a chance of zonular dehiscence,
yes,
if you want to use trypan blue, you will use it with caution.
we can use mixture of elastic substance with the trypan blue. Then we can prevent the migration of dye posteriorly. So we can use mixture, or either we can create a barrier by putting the viscoelastic in at the place of zonal dehiscence. So we can, in this way, we can prevent the posterior migration of the dye.
And also, it also highlights the importance of doing the AC wash after dye and then putting visco.
Yes. Proper AC wash before putting the visco.
Yes.
Visco.
Yes. Good presentation. So you want to ask, sir? So now I ask, thank you, Dr. Bhavesh, and now I invite Dr. Apeksha Kataria for her presentation. Dr. Sabyasachi Patnaik for a paper on stabilization of refraction following manual small incision cataract surgery. And I just announced Dr. Sakshi Makhloga. Is she So you can come and prepare on the other side of the podium. So Dr. Sabyasachi.
Yes, sir. Thank you, sir. So, respected judges.
So if the cat, yes. So cataract surgery nowadays become a refractive surgery, and sir will highlight the importance.
नहीं आ रहा है, मूव नहीं हो रहा है, कब होगा?
So may I know who is present at this moment here? Dr. Sakshi Makloga, Dr. Krupali Seth, Dr. Rutuja Raghavan,
नहीं करो, हाँ ठीक है.
Dr. Pratik Nishant. Sir, you
Can I start, sir? Okay, sir. Thank you, sir. Respected judges, now I am going to speak on stabilization of refraction in SICS. Delay in spectacle prescription following cataract surgery leads to a decrease in quality of life and productivity in post-operative period. SICS is often discredited for late visual rehabilitation in comparison to co-emulsification. So spectacle prescription still is recommended after 6 weeks post-op. So there are few studies to refute this. So the objective of our study is to determine the time required to achieve refractive stability following SICS by comparing the subjective refraction at 2 weeks and 6 weeks post-op, and to recommend changes. So method, after obtaining institutional ethics committee approval and written concept, 200 adults were selected who had uncomplicated manual SICS, and PMMA IOL was implanted. As 6 opted out, ultimately 194 cases were there. We exclude patients with history of glaucoma, any other pathology, traumatic cataract, and complicated cataracts. So statistical analysis was done by SPSS version 2. Descriptive analysis, categorical data were expressed as number percentage, continuous data as mean and standard deviation. Continuous variables were subjected to Sapio-Wick test and found significantly different from normal distribution. So we used for comparison Wilcoxon sign react test for unpaired data. So this is the demographic profile of the cases. Majority were more than 50 years of age. There are 103 males and 91 females. 93 right eye and left eye 101. So change in refraction was, no change in refraction was observed in 161 eyes, that is 83%. Change in refraction was considered as either no change or less than 0.5 diopter. Change in cylindrical in 19 cases, change in spherical in 9 cases, change in both spherical and cylindrical in 5 cases. So the majority of the patients had no significant change in refraction at 2 weeks and 6 weeks post-op. So these are the statistical value where there is no significant difference. So as there are not much of studies, we didn't have to, our conclusion says post-op refraction was stable from 2 weeks post-op. So our study conclusively proves spectacle prescription can be given to patients after 2 weeks following an uncomplicated SICS in the absence of any ocular pathology. So the prescription guidelines can safely be revised. The limitation of our study was it included only eyes with good visual potential and a good initial visual outcome. So refraction at both visits were not conducted by the same refractionist in every case. Hence, the degree of measurement bias cannot be ruled out. With these limitations still, we can recommend spectacle prescription after 2 weeks post-op in case of SICS. Thank you, sir. Thank you very much.
Dr. Patnaik wants to convey that the visual rehabilitation can be done after 2 weeks.
Yes, sir.
Usually we are doing it after 1 month, 4 to 6
1 month
weeks.
or 6 weeks, that is still the conventional in SICS mostly.
So he's doing SICS, he's a veteran in SICS, and he's trying to make SICS a refractive surgery also.
Still, it is
Thank you.
comparable in every aspect. Thank you, sir. Thank you, sir.
So it's about early visual rehabilitation. But sir, there are 6 surgeons, and all were having a different techniques definitely, and all have the influences on the incisions. And do you definitely do you have averaged everything? So do you recommend the protocol to provide spectacles for the a latter
No,
life for each and every surgeon for each and every patient?
no, that is not possible because it all depends upon your confidence level and expertise in doing the surgery, how competently you can do. But my point is, it is possible. Suppose this is not a contraindication or not a something very different from phacoemulsification where stabilization takes time, something there. That's correct. Given, yes, yes. And mostly that, from that only I got this point of thing. In many cases that didn't change. So that's why I thought why not to do a study on the change in refraction and then compare it. Thank you, sir.
One practical question. In fast-going life, everybody wants to see clearly within
As
days.
quickly as possible.
How you convince them?
No, people are convinced. It all depends upon the
They
confidence.
want to see closer nearly, distance
Closure
nearly,
we see in SICS, the
and
advantage,
they will compare you. They got operated there in
multifocal.
so
No, the
how
advantage,
you convince?
advantage with SICS is mostly there is 0.5 to 0.75 or 1.5 minus against the rule astigmatism. Usually that occurs in SICS.
That your patient is not going to understand.
No,
what
no,
you are
that
doing.
you have to
That you
convince
have
him
to
ultimately because it all depends upon his confidence on the surgeon whom he has decided to. Thank you,
Thank you
sir.
very much for bringing it the point to the forum. And now I invite Dr. Pratik Nisan for his paper on opposite clear corneal incision (OCCI) versus steep axis incisions on axis incisions in prediction of total corneal astigmatism during phacoemulsification.
Thank you, Chairpersons. Greetings to everyone. So this is my study, comparison of efficacy of OCCIs versus conventional single clear corneal incision in reduction of total astigmatism. No financial disclosures. Approximately 1/3 of patients undergoing cataract surgery are eligible for the treatment of pre-existing astigmatism, and not correcting this astigmatic component during cataract surgery will fail to achieve spectacle independence. This is possible using manipulation of the corneal incision parameters, not only the size, location, and shape, but also the number. There is an enhancement of an additive flattening effect of 2 opposite clear corneal incisions compared to 1 incision, and previous studies have documented this with a 2.8 to 3.2 millimeter keratome. However, modern phacoemulsification surgeries with 2.2 millimeter incisions, this effect is yet to be quantified. So the aim of this study was to compare the efficacy of adding an OCCI on the steep meridian versus performing surgery on the steep meridian alone during 2.2 millimeter phacoemulsification in reducing pre-existing corneal astigmatism. This was a retrospective clinical study including 34 patients with senile cataract who underwent clear corneal phaco with PCIOL, monofocal non-toric PCIOL. So this was the eligibility criteria as follows. All cases with disorders which could modify corneal astigmatism were excluded. After thorough pre-op examination, including BCVA, UCVA, refraction, slit lamp biomicroscopy, fundoscopy, tonometry, and keratometry, the measurement of total corneal astigmatism was done using the telecentric keratometry of the IOL Master 700, and all surgeries were performed by a single experienced surgeon without intra-op or pre-op limbal marking using the approximate limbal landmarks as seen on the slit lamp examination. Patients were divided into 2 groups. Those with astigmatism less than 1 diopter were in group 1 and had single incisions on the steep axis. Those with astigmatism greater than 1 diopter had OCC as made after IOL implantation with a visco-filled anterior chamber. Post-op follow-up at 1 week, 1 month, and 3 months was done with total keratometry, and the results were statistically analyzed using t-test, and p-value of less than 0.05 was taken significant. Of the 34 eyes meeting inclusion criteria, 17 were allocated to each group. The groups were comparable at the baseline in demographic parameters, and there were no statistically significant differences. This is the table and the chart. The baseline astigmatism in the two groups was significantly different. Both groups achieved statistically significant correction of the total corneal astigmatism at the end of 1 month. The net change of astigmatism achieved at the end of 1 month for group 2 was approximately double as compared to that of the group 1. This is also shown in this chart. At the end of the third month, we had a significant attrition of the number of patients. However, the results were comparable with the findings at 1 month, with approximately double correction of astigmatism achieved with two opposite corneal incisions and mean correction of 0.62 diopters. Astigmatism is a major cause of suboptimal vision after cataract surgery. Other existing modalities for treatment of corneal astigmatism have their own disadvantages. A steep meridian corneal incision for phaco is recommended to reduce astigmatism, but a single incision is insufficient if astigmatism is beyond 1.2 diopters. OCCIs are self-sealing, pose no additional risk, require no surgical equipment extra, and are effective in reducing astigmatism. How effective? Previous studies have shown that variable correction of astigmatism is possible with 2.8 millimeter or 3.2 millimeter OCCIs, but this effect is not yet documented for 2.2 millimeter opposite clear corneal incisions. In our study, a 2.2 millimeter keratome was used, which explains the smaller change observed compared to previous studies. We observed that this has encouraging results in correcting mean astigmatism by 0.57 diopter, even in the short term of 1 month of follow-up. However, a final mean correction of 0.62 diopters was achieved at the end of 3 months, which may imply that a fair stabilization of astigmatism is achieved by 0.57 month, 0.57 diopters, even at the end of first month with opposite clear corneal incisions also. The study has limitations of retrospective design, small sample size, and loss to follow-up. Long-term outcomes and larger sample size may be necessary to establish the quantum of effect that this 2.2 millimeter OCCIs may have in correcting the corneal astigmatism. To conclude, OCCIs are reliable, easy, and cost-effective for management of mild to moderate pre-existing astigmatism, and the enhanced effect over the single clear corneal incisions is demonstrated by this study. These are my references. Thank you.
Just one question. You are doing the surgery from the superior limbal or temporal limbal?
Sir, the steep axis was determined by the keratometer, and the main incision was placed at the steep axis, at approximately the steep axis, as was determined by the limbal landmark on the primary slit lamp examination. So it can be superior, it can be superior-temporal, it can be sharply temporal, might be slightly inferior-temporal also, up to say 20 degrees or so, might be superior-nasal also.
Definitely. And another point, it means it was variable in your study.
Yes, sir.
Not site-specific, on-axis incision.
On-axis incision.
And the other point, what you did with the OCCI, how you just made an incision, or you did some maneuvers through OCCI?
No, just made an incision and then sealed it in the routine process.
Okay. So it's...
Have you noticed an oblique incision opposite to steep is better, or just opposite to that steep axis that is better?
On axis steep incision, on the steep axis, if the incision is placed, then it produces flattening and correction of the
Suppose
pre-existing
steep is
astigmatism.
180 degrees, so where should be your incision?
180 degree. So my primary incision will be placed at 180 degree temporal, whatever is, whatever is, whichever point of that line falls temporal. And my opposite clear corneal incisions will be about 180 degrees away. So that would be sharply nasal.
So definitely the previous study, just to point it out, that's whenever you are making an OCCI incision, it is then working, it's creating some influence when you are doing some maneuvers like IA at the end or like that.
Yes,
Number one. And the other point is that whenever you are doing OCCI, especially in a superior segment, has a different effect on the astigmatism.
Yes.
Temporal segment has a different aspect on the astigmatism. So we cannot generalize all those things. Definitely we can compare it, but and 2.2 millimeter incision as documented in the previous studies are very less astigmatism inducing.
Exactly.
That's why that's a microincisional or
Exactly.
You
So,
can
so the objective of this study was, say, we do not use a larger keratome. We do no maneuvers through the OCCI per se. We don't use a preoperative or intraoperative limbal marking system. This is just as simple as it can get. And let us see how much is the effect that we can achieve. So a 0.6 diopters of correction is quite a fair effect for someone, say, coming up with 1.4 diopters. He gets a 0.8 at the end of the 3-month period. So this is the quantum of effect that we could document with this small study. And definitely, probably larger studies with comparison of the superior and temporal subgroups would probably give more insights into this kind of a picture that we have got.
And also this because its follow-up was for a very short period. So even in OCCI, it was said the results are suboptimal over a period, over a larger period of.
Exactly,
So
exactly,
you
sir.
need to have a larger
So
follow-up.
that is one part of one limitation of the study which has been acknowledged. But the practical aspect of this is that cataract surgery patients usually do not follow up for a very long time until the cataract of the other eye is very significant, or maybe they have some other ailment, say glaucoma or something that they come to you with. So this is something that the follow up is quite difficult to achieve practically.
Thank you, Dr. Pratik, for bringing the new things in that one. And I just am asking to the audience that so Dr. Apeksha Kataria present, Dr. Sakshi Makloga, Dr. Krupali Seth, Dr. Rutuja Raghavendra Taligavekar, Dr. S.K. Pandey, Dr. Suresh Kumar Pandey, Dr. Pransu Goyal. Yes, please. So Dr. Pransu Goyal is presenting his pre-paper on PCO and NDR capsulotomy rates in patients implanted with a square and non-square edge IOL in micro and small MSICS, manual small incision cataract surgery. That's good. Good area. It's what difference these are going to make on a patient.
Good morning, everyone. Good evening, everyone. My study is on posterior capsulopacification and NDR capsulotomy rates in patients implanted with square edge and non-square edge IOL in manual SICS. No financial interest. PCO being most common post-operative complication of cataract surgery. Main etiology being the proliferation, differentiation, and migration of the lens epithelial cells. One of the ways being the square edge IOL was studied in this group, and the need for NDR capsulotomy. A randomized study, a controlled trial in a tertiary healthcare center over a period of 18 months with a sample size of 104, 52 in each group was studied. All patients undergoing manual SICS in the age group of 50 to 80 years were included. Small people, pseudoexfoliation, traumatic cataract, complicated cataract, subluxated cataract were excluded. If intraoperatively pre-existing PCO or extended rhexis or posterior capsular rent or sulcal placed IOL, then the patients were excluded. Preoperatively, base correct visual acuity, slit lamp examination, tonometry, retinal evaluation, A-scan biometry, and IOL power calculation was done. A single surgeon performed all the surgeries with 5.5 mm diameter capsular rhexis and in the black placement of the single piece PMMA IOL with 6 mm optic with square edge in group 1 and non-square edge in group 2. Follow-up was taken on day 7, 1 month, 3, 6, and 12 months. The corrected distant visual acuity and slit lamp examination was done on every visit. Posterior capsule opacification was assessed. The retroillumination and images were obtained after full mydriasis. And if in the central 3 mm area PCO was present, then the patient was considered for NDR capsulotomy. Status analysis was done using t-test and KaiQS test using SPSS software. Patients in the two groups were age and sex matched. The mean age in group 1 was 64 years and in group 2 was 65 years. There is a table showing the best corrected visual acuity in the two groups, pre-op 1 week, 3 months, 6 months and 12 months follow-up. As according to this table, there was no significant difference in the best corrected visual acuity between the two groups at pre-op and immediate post-op. But at 12 months on follow-up, the visual acuity in square edge group was significantly better than the non-square edge with a p-value of 0.013. In the non-square edge group, 2 patients needed NDA capsulotomy and on 12-month follow-up. This is the few slit lamp images of non-square edge IL. As you can see, on 1 month, there is significant PCO and patient was posted for NDA. In square edge, even after 1 year, no evidence of PCO. Comparing the NDA capsulotomy rates with previous studies, our study was sample size of 104 with mean age of 64 with 2% patients having NDA capsulotomy in non-square edge group. In a study by Arvind Harpriya et al. With the sample size of 94 and mean age of 53, having 0% at 1 year and 2% at 2-year follow-up in square edge, and 1% at 1 year and 37% at 2-year follow-up in non-square edge. In a study by Jagat Ram et al. With mean of 61 years and sample size of 377, square edge in PMMA, silicon, acrylic hydrophobic and acrylic hydrophilic were compared at 2-year follow-up with NDA grades of 11.7%, 1.4%, 3.6 and 6.8 respectively. In a study by Rekha with 128 sample size, a mean age of 62 years, having 1.6% at 18 months follow-up and 3.1% in non-square edge group. The rate of occurrence of PCO is significantly less in square edge IL than non-square edge IL. So we suggest that the square edge IL implantation in place of conventional round edge IL would be useful in lowering the rate of occurrence of posterior capsular opacification. These are my references. Thank you. Sir, that square edge IL should be used because in previous studies also and in this study also, it needs, sir, further post-operative follow-up also because I did the study till 1 year follow-up. I'm still continuing my patients after 1 year also, and I have not included those in the results, but still in the square edge group, I have not seen any posterior capsule opacification, and in till 1 year period, I found 2, and till now, I have found more 2 or 3 patients which required NDA capsulotomy. So I would recommend that square edge IL should be used.
So can you tell me how a square edge IOL, a square edge design of the it's on a posterior surface,
Yes, sir.
how it prevents the by which mechanism it prevents the PCO?
Sir, the lens epithelial cells, the cortical matter which remains, so it will not go behind the lens. The square edge will stop the lens epithelial cells from going behind the lens. In square edge, it can easily go behind the lens and proliferate over the posterior capsule.
Yes, it prevents the LEC migration.
Yes, sir. That's the theory also which I told, that the migration proliferation of the lens epithelial cells.
One question arises.
Yes, sir.
In all cases, surgeons were the same? Or
Yes, sir. Single surgeon.
Single surgeon?
Yes, sir.
They did, that's right.
Okay, thank you. Thank
Thank
you.
you,
So now I invite the finalists of Cataract Session 1.